aspect. So now we are there for the panel discussion, and over to you, my dear co-chair, Professor Asma Deep.
Thank you, Mohammed. That's great. Let's have a 10 minutes discussion. Walid, Prof. Iraqi, Nancy, and Reem. Let me just start with a couple of questions to Walid, and if you kindly, speakers, give us a precise answer so we can utilize the time more efficiently. Walid, you mentioned, you were talking nicely about CGM, and then you said it would be nice if we can have randomized control trials to look at CGM compared with self-monitoring. Do you think we can ever succeed to have such a trial with everybody nowadays, at least in your center and my center, using CGM? Do you think you will be successful in enrolling patients who are now used to CGM as a standard of care, and you come and tell them go back to SMBG for the sake of the clinical trial to be done by Prof. Kaplan?
As a matter of fact, our most recent data collection at T1 showed that at least 1/3 of our patients are still on SMBG. So even when we have patients who have a very generous insurance that covers everything, more than almost 36 or 37% are on, as of today, still using SMBG. So theoretically speaking, the study would be very useful if it's done by scientifically by randomizing two groups, one on SMBG and blinded CGM, because if you put them on SMBG only, you will not be able to tell what happens with them on an hour to hour. So it should be an arm on SMBG with blinded CGM, and then the other group on CGM. We will get the benefit. But to answer your questions, at least 1/3, if not more, in my center are still on SMBG. And as we've heard from Morocco and other places, probably a lot more are still on SMBG. So it would be fine to have an evidence-based answer to this question that keeps coming: is CGM useful or not? Number one, is CGM useful in Ramadan or not? That's number two. I think we should have such an answer in a scientific.
Yeah. I mean, I fully understand, Walid, that you have 1/3 who are still on SMBG, but I'm talking about randomizing patients. With the model you are talking about, you can have two parallel groups, one group on SMBG and one group on CGM, but I find it not really feasible, at least talking about a center like mine, to randomize people, because if you have 70% of your patient on CGM, when you come to randomize people, there might be you asking them, don't use CGM, go back to SMBG. But yeah, thank you. We got your answer, as you might still be able to do it into two parallel arms, one with SMBG, but again, randomization will be difficult. Walid, a very quick...
Asma, for clarifications, you're not going to take patient on CGM and randomize them to SMBG. You're going to take a cohort on SMBG and randomize them into a CGM or SMBG with blinded CGM from the same cohort. As you can see, most of the Ramadan study we have done, unfortunately, the sample of the cohort is as few as 5 patients to maybe, in a best scenario, below 100. So you can easily have a group of 20 to 30 patients on SMBG and another group on CGM from the SMBG group, which again, in my center, we have at least 100 patients still on SMBG.
Okay, that's great. I think Dr. Effendi was challenging you with a question in the panel. He's challenging you with 2 questions, but I'll leave the second one for Prof. Iraqi. The first one, he said, Dr. Kaplan, you seem to be talking confidently about the safety of type 1 fasting, yet you did acknowledge that the unrevealed hypoglycemia, when you looked at your CGM data being higher during fasting, So he gave us a feeling that you're contradicting yourself. I know you're friends, so you're not going to be offended.
I replied to him, and he sent me a private message with a sense of joke to let me know that he asked this question. We keep this debate running between Bashar and myself. Well, first of all, for a clarification, I did not say that the hypoglycemia was higher during fasting. Actually, it was not higher. It was similar when we take it as a percentage, 24 hours per day, fasting versus non-fasting in the same cohort, it was not different. So the hypoglycemia, the hyperglycemia, the mean glucose for 24 hours was very similar in the same cohort between Ramadan and Ramadan. So I answered Bashar again to clarify, I am not saying for type 1 diabetes who fast Ramadan, they will have a lovely glucose reading. No, they can have a very funky readings and a wide fluctuation as I have shown in my slides. But at the same time, I am saying that those same patients who live outside Ramadan, they continue to have the same fluctuations. So why are we only focusing on these fluctuations and the hypoglycemia and during Ramadan, while we don't mention about it when it happens outside Ramadan, and it does happen outside Ramadan. So actually, we're not managing our patients properly. We have to admit the failure. As of today, we're trying and working hard, whether with the help of technology or something else, to improve the control of type 1 diabetes. Once we do better, that's going to reflect more on Ramadan as well as it does on outside Ramadan.
Okay, well, thank you, Walid. I was waiting for you to share the joke you said to Bashar, but you remained serious, so I'll leave you there. Okay, Reem, a couple of quick questions to you. One of them, again, about enrollment in studies in general. How did you manage to persuade people to take their Lantus at 6 p.m. when this timing can be during the fasting time? Some people say, no, injecting will break the fast. Did you find that easy?
Yeah, thank you for the question. It was between 6 and 7 p.m. because the study was between 3 cities in where some of the cities, like Pasandamam, the Maghrib was actually around 6. It was like 6:45 or something like that. So it was in general 6 to 7 at Maghrib time. This was the general study protocol.
Your study is fantastic because when we talk basal insulin, we have two main issues. One issue is what time do we give basal insulin? And the other question is, do we reduce the basal or not? So I followed your presentation. I didn't even blink when you were presenting, but I haven't heard anything from you talking about the dose. So I'm finding it a little bit difficult to take directly your conclusion. I'm going to go tomorrow and I'm going to feel free about this 6 p.m. and 12 p.m. Did you look into the adjustment? It was 6 centers, multicentric. So maybe people in Medina, they're not doing it the way you are doing it. So do you see your questions? Everybody reduced basal or everybody didn't?
No, so the reduction of the basal was left to the discretion of the treating physician and during the education and depending on A1C and all. Yeah, so we did reducing the dose was not part of the protocol, but the timing was. So whatever you're going to do as pre-Ramadan, do it. The only difference is timing. But when you look into the data, about 33% in both groups did reduce dose. But that was part of the whole general Ramadan management from the pre-Ramadan education. So it was about 33% who reduced their doses. Well, average dose in both groups was about 24 as a baseline.
So most of the centers, all of the centers followed the same protocol. Yeah. Okay, let me move to Nancy. Great to see you, Nancy. I mean, we understand how good insulin pumps are in helping pumpers to fast safely. What's your expectation? And we've seen Goran's study, and you talked about the 670. But how do you feel about the newer versions of the advanced hybrid loop, the 780, for example, are we going to have 100% time in range? Everybody will not have hypo, nobody go to ER. What do you think will happen?
Thank you, Asma. You're the big boss of technology in the region.
Not
so
really.
I really like the question, because the expectation now, as we are having in our region, the hybrid closed loop, which is the 780G, we are actually seeing now, before Ramadan, as I have shown you in the last slide, that the patients already can reach 100% time and range using the closed loop. So this is manageable with this newest version, because we are having an automatic basal adjustment every 5 minutes when they are using the Smart Guard auto mode. And again, they can do a temporary target glucose range to prevent the hypoglycemia. And this is again connected with the predictive low glucose suspend. So I saw Dr. Ahmed Hassoun, and thank you so much for joining us. He asked me about if we can change the insulin sensitivity factor in order to adjust the insulin basal as well as bolus to avoid both hypo and hyper. But let me simply tell you that with the hybrid closed loop, there is no adjustment of the insulin sensitivity while you are on the O2 mode. So everything is being done automatically without the patient changing anything in his insulin sensitivity factor. What he can do actually is simply change the insulin to carb ratio, increasing the amount if it's more than 100 grams of carb, which is definitely this will occur, and they can do the splitting of the bolus in a normal way, just like giving the 40-50 before and then the 50-60 after, and then go a temporary target if they're having hypoglycemia. So definitely the hybrid closed loop will shut off those lows. And now we are expecting even the newer version of sensors, the Guardian 4, that will have more and more efficacy rather than the one which is now.
Okay, great. Thank you very much, Nancy. Now that you mentioned our colleague Ahmed Hassoun, can I quickly go back to Reem, please? Because Dr. Hassoun, yes.
Can I just ask Nancy again? I think it was not clear. If you don't mind.
Okay.
The question is about.
Sure.
Can you hear me, guys? You can hear me,
yes,
right?
yes. Go ahead.
Yes,
go
I
ahead.
can hear you clearly.
Just to clarify my question, you know, it is an auto-adjusting its ISF by itself. So my question was, during the first few days of Ramadan, when the patients start facing different, rhythm and, way of fasting and not eating, you will need the time to adjust to make an ISF, a new ISF for the patient. Is it enough time to be safely doing that in the first few days of the fasting while on 78G? I understand your answer, but the question was different.
Yes, definitely, because if you are on the auto mode, the algorithm already understands the adjustment of your basal dose. That's why I asked, when you're on the auto mode, you're definitely not moving the insulin sensitivity. The pump will never even look at the insulin sensitivity adjustment on your basal rate. So it is enough because it is automatically done through the algorithm. And as long that the patient is already within good time and range before Ramadan, so just making a longer fasting hours, making only basal adjustment will make it easier for this Smart Guard technology to adjust the basal rate even without looking into previous insulin sensitivity factor. It is done, actually, most of our patients even are saying now, the pump will do it marvelously during Ramadan because it is automatically adjusted. So we are waiting, as Asma is saying, time and range 100%. And we can show later, inshallah, next year within the presentation, the outcome of the hybrid closed loop using this algorithm.
Thank you very much. Well, you had the opportunity to ask it yourself. I still would like to have 30 seconds for Reem to ask an interesting question. Your study was during COVID. Would the result be any different if we have no COVID, if we ever have no COVID anymore?
Well, I don't believe that COVID specifically affected our study because we've seen this before with our Ramadan Saudi population in general. It's a blessing. Maybe in Saudi we do have very relaxed working hours from 10 to 2. For the last 10 years there hasn't been school. So in general, every time we do a Ramadan study, we find the same findings when it comes to the sleeping hours until noon or until the afternoon. So I don't think COVID specifically had a major effect compared to other years. But maybe during the coming years, since now Ramadan is coming more towards the spring and there's going to be more school, maybe it will affect the overall risk of hypoglycemia because people are more active. However, when it comes to the question of timing of basal, I don't know the answer, but it doesn't seem that it makes a big difference because even if we look into the Mocha et al. Study, the one that he did 18-hour fasting, and then he compared the fasting versus non-fasting days, and he had people walk twice a day for 30 minutes. There wasn't that much of a difference when it came to the pattern. So in relation, but there in both groups, they all took it at bedtime. So there was no comparison on about time. But generally speaking, I don't think that the time makes a huge difference as much as other factors inherent to the type 1 diabetes itself, and how the patient is, what's his risk of hypoglycemia, what's his individual pattern. And I think at the end it's all about individualization and for every specific patient more than a general rule for everybody. That's what I think.
Yeah, and I suppose you will be able to answer the question only when COVID goes away and you repeat the study. Let's keep fingers crossed. My last question before I hand over to Dr. Hassan.
I'm really waiting for a very long time, Asma. I'm really jealous now with all these questions. I want to have an opportunity and ask some questions.
So why don't you go ahead and you ask Dr. Iraqi? I will stop there. Thank you very much.
Thank you, Asma. I'm really delighted with the moderation and the questions flying from the faculty and coming into live as well to ask questions. It all tells about the diversity in type 1 diabetes. We have heard completely diverse approaches, and we have seen this in the studies. I suppose, Hind, what you presented is a case that is faced in so many countries, and I guess all a doctor can do here is pray that the patient will not end up with more problems. I know from the data, so my question to you is, in Morocco, in Algeria, in Turkey, and in many other countries, the rate of fasting in type 1 diabetes is much lower than other countries. How do you think you in your countries have came to that pattern, which is the opposite to the pattern in other countries, such as, for example, Saudi Arabia, where the fasting for type 1 diabetes is the norm?
Thank you, Mohammed, for this question. Yeah, I think in our countries, we are working for many years with the imam. For me, this is the clue to convince the patients. For example, in Morocco, 1 month before Ramadan and even the beginning of Ramadan, we have a lot of campaign and a mixed campaign with the imams and doctors. And we teach them each year what are the risks, especially with insulin, etc. And then they do khitab, they do dars about the risk in the mosque without doctors, and they directly ask the patient not to fast. So I think this is very helpful. For example, when I have a patient and I know he's in a high risk and he really wants to fast, I told him always that I'm going to help him to have less complications or that to fast without many problems. But I ask him to go
to see his imam, and all the imam says the same. For twice, I have a patient who came and told me, "Oh, my imam told me I should fast." Really, I went to the mosque on Friday and I pray in the mosque. It was not my near my home, and then I asked the imam if I can speak with him, and I told him what happened. Then he told me, "Okay, you're right, and I am going to do another course, another dars, and I ask your patient to come again." In that region, the quartier where he was, I think no type 1 is going to fast, because he was very, very, very convinced after that. And I think this is really what helps us, because only doctors, it's not enough. We say the same. We say there is a risk, and they may not have hypo. They may don't have hyper. They're not convinced. They're really more convinced by the imam.
Thank you very much, Hind. I suppose the new risk calculator had opened the door to many people to be able to fast, and some wouldn't be able to fast. Let me ask you, Professor Nancy, an important question. Now, the situation is the data is a bit biased by those who decided to fast. All the studies are done on those who decided to fast. So the selection bias is already there. We are checking or looking into the results of those who are eager and want to fast, and perhaps they feel a bit more able. Now, my concern is the young person or the type 1 diabetic who doesn't want to be bullied in his community, in his school, in his university, or even at work by not fasting. How can we help the community to understand that so many patients need to exercise their right if they want to not to fast, rather than being pushed to fast and then see a very high rates of hypoglycemia? The data of Saudi Arabia versus the others had the highest rates of fasting, but also had much, much higher rates of hypoglycemia. So it's not about who should fast or not, but the better selection. What do you think we should do to avoid the bullying or the peer pressure of the patients?
Okay, so thank you, Professor Mohammed, for the invitation and for the question. So Dr. Araki has already mentioned about the role of imam in the mosque and how they should address this. But let me shift gear into another thing, important thing, which is the parents, the family, the grandparents, as well as the brothers and sisters, and let me add friends at school. If they face the pressure from parents, for example, you should fast in order not to be bullied that you're not the same like your friends at school or your brothers and sisters. This is very important. So as you can see, also in my conclusion, I put the technology side, but on the other side of the coin and the balance was the education as well as the family support, because we will never make it and succeed if you don't have the support of the parents, grandparents, as well as the brothers and sisters. This is very important. They do understand that they have the choice. They do not go into fasting. However, majority of them, it's not just the social pressure, but actually it's their own belief. It's their own religious belief that they need to go in fasting. And even as my dear friend Asma, my dear friend Waleed and Reem, they have already implicated how with just simple insulin adjustment, we can make it. So it's not even without technology. It is safe. And again, Waleed mentioned a very important point that they do face the hypo and hyper even in the normal days. So fasting does not add, provided they are well educated and they can manage the MDI. So support is very important in those cases.
And do you say this statement categorical for all patients or for selected patients with good hypo awareness and with good control and with frequent SMBG.
Definitely. So
Because
yes, we are getting back to the risk factor.
Hundreds of people now are still logging in despite being so late. And my concern is they might take these statements and think that it is okay for all people with type 1 diabetes to fast, where many of them have, similar to the case that we've just seen, checking maybe once a day maximum, or haven't got the means, or maybe have hypo unawareness. Some of Reem's patients had hypo unawareness. The Walid's data from before, from Al-Ain, also had many patients with hypo unawareness. So it's about the risk. Of course, doesn't mean that everybody will develop a problem, but it's all about the risk. And one fatality or one serious hypo damage is one too many. So I love the guidelines that you put, guys, for the SPAD, when you categorically said, provided many factors being available before a person can fast. Dr. Walid, final point, I want to ask you, all of you are very good friends and you're working in excellent centers. It's an invitation. We have the next guidelines, perhaps in 3-4 years, is to conduct the type of studies that will give us the answers. Because currently, as many of you have presented, we're talking about small center trials of 20, 40, 50, 60. And there is a lot of bias as well from the centers where perhaps with culture or lifestyle. We'd love to see a big study in many centers. We have many people enthusiastic so that we can be better in the future with more evidence.
I would love to work with anyone. I think nobody can disagree about this statement. And I think we're moving into that direction. Thank you to this initiative, Diabetes and Ramadan, and this annual conference is actually a motivational event to make us all work harder toward achieving that goal. I'll raise my hands though for a comment and a quick question if there is time.
Sure, go ahead.
So let me lower my hand first. So the comment, I'm not sure if Dr. Hind is still with us or not, but I definitely agree with her that it is unsafe for a type 1 diabetes patient to fast Ramadan and check his blood sugar once a day. But at the same time, I do believe that it is unsafe for any type 1 diabetes to live any day of his life outside Ramadan, taking insulin 2 or 3 times a day and still checking his blood sugar once a day only. So here we are again, we're biased into putting all the blame on Ramadan, but at the same time, we're not doing campaign to push on our government and charity organizations to provide more resources to those patients so that they can do the least they should to minimize the risk of type 1 diabetes. And we have seen this in Eastern Europe with the economic situation being not as fortunate as in the Gulf. So that's my comment. My question to Dr. Reem is, your cohort is mainly adults. I know you did see patients from 15 and older, but the mean age, I believe, was 21. Do you feel comfortable saying the same for a young adolescents? We know that insulin profile is not exactly the same in young adolescents and adults because of the higher metabolic rate. So would you feel comfortable giving the same statement to a 12-year-old?
Which statement are we talking about?
That there is no difference by giving basal insulin at iftar or late evening.
Yes, we didn't have any 12-year-olds. We did have 14 to 18-year-olds, about 33% of our population. I cannot make that statement because I don't have the study that in that population. But I think physiology, more or less, when it comes to timing, I would assume from like the study of Dr. Debo, she didn't find a difference. From the study of Dr. Azeri, that didn't find a difference. So everything is supporting that it doesn't seem to be the time as much as other factors. So, but for sure, we're going to have a randomized study in children to say that as a statement. Yeah.
Thank you.